Okay, we are officially recording. So this is the Unit 6 exam review prep session that we always do prior to the exam. Before we get started, I did have some questions, just really brief, I want to address about the final exam. The final is scheduled for Friday, May 8th. Back in mid-March, when the college went online and they were kind of figuring how this was going to work, because of the week we lost after spring break, it was the extended spring break, academic affairs essentially changed finals week. Instead of it being a formal finals week, it became an instructional week. So basically, faculty were told we have to administer whatever final we were going to do, we have to administer during regular class time. So obviously, our class time is Monday, Friday, in consideration with the other courses, because I know pretty much, I think all of you or the majority of you are taking topics, and also some of you are taking pharmacology. So in looking at that, I spoke with Mrs. Weaver, and she indicated that there is a topics presentation that's due on Monday. That is why I elected to choose Friday for our final. Plus, it gives you some additional time to prepare, but that was the reasoning for that. Now, that being said, I am going to, on Wednesday, May 6th, I am going to have a Zoom session just like this one, the way I do prior to an exam, but it'll be focused on the final exam. So I actually did add that to the calendar in Plato, and I will also have an actual link in a Plato announcement later on today or tomorrow with a little bit more specifics about the final. But I just wanted to address that. I know there was some confusion because when the college made that change, they also did not update your SIS schedule to reflect that. So I understand that there was definitely some confusion there. So I apologize for that. I was not aware that they did not update the SIS. But the exam for us, the final exam, is going to be Friday, May 8th. It is synchronous. So that means all students will need to start at 12 o'clock. So it won't be like today's exam and the previous unit exams where you have a window where you can access it. All students will need to access the final exam at noon. Once you access it, then you have the 120 minutes to do it. So, but the time that you have to access it is going to be right at noon. So I can entertain any questions related to that towards the end, but I want to kind of get moving on to why we are here, which is kind of a last minute push review for Unit 6. So I'm just going to start with the chat questions. So go ahead and, throw those on the chat box, and I'm just going to kind of work my way down. So first question, when a patient has a stroke, do you not want to elevate the bed more than 30 degrees? That is correct. It obviously depends on the situation and exactly what you are doing with the patient. But initially, we do not want their head of bed above 30 degrees because our concern is the potential for increased intracranial pressure. So having the head of bed, generally we say about, 20 to 30 degrees, really no higher than 30. That helps facilitate venous drainage back down towards the heart. The other thing that's important to keep in mind, again, in addition to the head of the bed elevation, is also keeping the neck in a neutral position, okay? So if they're facing forward like this, I have a nice straight drainage from the jugular veins, okay? Which is very important because if you have stuff blocked off and it's not freely flowing, that backflow up in the brain can cause increased pressure. So it's very important that we're keeping the head in a neutral position. So we're forward facing, we're not turned to either side. We don't have it hyperextended. We don't have it down towards there to help facilitate that drainage. Now, that being said, if you are feeding a stroke patient, you absolutely need to make sure they're elevated. Typically in the initial acute phases of the stroke, that's really not our priority. At that point, we're keeping them hydrated, using IV fluid and that, a day and a half, 2 days of decreased nutrition is not going to kill them. It's not going to cause as much harm as a spike in intracranial pressure would. So, you need to look at what the priority is at the time. As that stroke patient is moving into the rehabilitation phase, and they're recovering, the risk for increased intracranial pressure is not as high. So then we start going with our normal basic care. But that initial emergent acute phase of stroke care, yeah, we are concerned about the increase in intracranial pressure, more so with your hemorrhagic stroke. Because remember the difference between the ischemic and the hemorrhagic stroke. The hemorrhagic stroke, you've had a rupture of a vessel, and now that blood is out into the brain tissue, pushing on the ventricles in the brain, and you have that increased in pressure. Okay, so good things, good questions. All right, let me scroll back up here. Okay, going over the staging and the grading of tumors. Okay, sure. So let's break these up. Let's start with staging. And staging when we talk about solid tumors. Now remember, this is different for leukemia and your lymphoma. Those are just done, you know, based on cell morphology. But for your solid tumors, we use the TNM staging you know, system, I guess you would call it. The T stands for tumor, and the tumor is given a number essentially from 0 to 4. The higher the number, the larger the tumor is. So if you were linking this back to the Susie video case study, her tumor was rather large. Now, I don't have her actual staging, but I would be willing to think at that point, hers was probably at least a T3. So it has to do with the size of the tumor. The N has to do with the nodes. So we look at that in relation to regional spread. So has the cancer spread to the regional lymph nodes? And the extent of that spread and the number of nodes involved is going to kind of determine the number that the N is given. So just like the T can go from 0 to 4, the nodes, the N can go from 0 to 4. Okay, and then the M piece is metastasis. So now we're looking for distant spread. And it's either present or it's not. Okay, so it's a 0 or it's a 1. It's either there or it's not. So when you look at the staging piece, it goes back to the basic premise of the larger the cancer is, the more it has spread regionally, the more it has spread distally, the more advanced the cancer is, the more difficult it is going to be to treat. So in general, as the patient's TNM numbers go up, they're going to have a poor prognosis. Okay, if we're looking at, you know, are we going for the cure here, or are we looking to try to minimize the cancer and extend life, but knowing we're not going to fully achieve a cure? Or are we looking at palliation, keeping the patient comfortable? So that's how that staging piece works. So grading kind of runs the same way, but it just has some slight differences. So when we talk about grading, we're actually looking at the physical appearance of the cancer cell underneath a microscope. And grading can go from grade 1 to grade 4. Okay, and the same thing, if you're going to have it, the lower the number, the better. And essentially just looking at these cells underneath the microscope, as a cancer becomes more advanced, the cancer cell itself looks less and less like the original normal cell it was. So for example, let's just take liver cancer. If I look at a grade 1 liver cancer, and I look under 2 microscopes, I have a normal liver cell and I have a grade 1 liver cancer cell. They're actually going to look pretty similar underneath the microscope. There will be some slight differences, but you would still be able to tell this is a liver cell. By the time you get to grade 4, if you didn't know that this was a liver cell, a grade 4 cancer liver cell, you would likely have no idea what it truly was just by looking at it underneath the microscope. So the cell becomes more and more abnormal. It becomes abnormal in appearance and it becomes abnormal in function. So that's what we mean by the staging and the grading. And just like the staging, with the grading, the higher the number, the more advanced the cancer is and the more difficult it is to treat. Okay. Do we need to know any specifics, diagnosis, treatment, signs and symptoms of lymphoma, leukemia? No, not this. When we talk about these concepts, this unit focuses on basic oncology concepts. So that's really how I approach it, because when you graduate from this program, you are not expected to be an expert in cancer and cancer diagnoses and cancer treatment. As a nurse generalist, you do need to be familiar with the basic concepts. So that's what I want you to focus on. So that being said, if you're looking at a test question, and it may refer to ovarian cancer, it might refer to breast cancer, the answer is not going to be specific to that type of cancer. It's going to be based on those general basic concepts, okay? If I'm talking about how you treat, cervical cancer and the prognosis of cervical cancer, and you have somebody who's stage 1 versus stage 4, it's understanding that stage 4 is more advanced, it's spread, that person's going to have a poorer prognosis than somebody with a stage 1. Okay, so that's where it's coming from. Same thing with chemotherapy meds. There may be the name of a chemotherapy drug in a question. Okay, your answer, the correct answer, I should say, is not going to be specific to that exact chemotherapy drug. I want you focusing on the big concepts like we talked about the last 2 Zoom sessions. Your chemotherapy drugs, they all pretty much have the same side effects. So looking at those side effects and focusing on the nursing management. Okay, how are you taking care of a patient who has thrombocytopenia? What are you assessing? What are things that you're not doing because this patient's at risk for bleeding? Okay, playing flag football would not be appropriate, and certainly not tackle football. But just kind of think about those things that you would be doing, to keep them safe. And then also, are there medications to improve that condition? So we talked about in the CSF medication worksheet, the 3 different meds, and when we would use them in relation to boost the particular blood cell that they're associated with. So it's looking at the nursing care aspect of that, okay? What are the major differences between MS, myasthenia gravis, and Parkinson's? Okay, so let's talk about the similarities and then we'll kind of hit the major differences. So similarities, these are all chronic neurological conditions. So what's different about them, and we'll kind of hit this a little bit more in just a minute here, is the pathophys. What is the cause? Like, what is causing the actual problem? And the reason you need to know that is because that's going to help guide treatment. Certain medications we use for MS, certain meds we use for MG, Parkinson's, because we're treating the cause of the problem. Okay, but beyond treating the cause of the problem, just like you had the similarities between pneumonia, asthma, cystic fibrosis, things like that, you have these similarities between your chronic neurological disorders. And I would say these also apply to your stroke patients that are in the rehabilitation phase. Remember, the whole goal with your chronic neuro conditions is to maximize the client's function. We want to keep them as independent as possible for as long as possible. We want to maximize the function of every single body system, and we want to minimize the risk for complications. So regardless of which one we're talking about, they all are going to have an impact on mobility. Now, MS, it's going to be a progressive thing. Parkinson's is going to be progressive. Myasthenia gravis, not so much mobility, but it's more about muscle strength. And with myasthenia gravis, as your patient progresses throughout the day, they're going to get weaker and weaker. Now, their muscle strength does regain with rest. So that's why it's very important for your myasthenia gravis patients, really for all of them, but especially myasthenia gravis, that these patients have very frequent rest periods. Because if you keep them going and going and going, they are going to max out their muscle strength very early in the day. And again, we worry about meal times with myasthenia gravis because of the muscles responsible for swallowing. And we worry about respiration. Your diaphragm is a huge muscle, controls ventilation, and those are our 2 biggest concerns for myasthenia gravis. Okay, so for them, that's why the timing of the medication is so important, that 45 minutes to an hour before meals, because we're trying to maximize the muscle strength for, eating. But it's also, that's why it's important to space your activities throughout the day, and they have to have frequent rest periods. with myasthenia gravis. With MS, they're going to have muscle spasticity, you know, they're going to have an effect on mobility. And that's really going to be probably consistent throughout the day. Those symptoms will get worse with an exacerbation. So if you think back to things that are going to cause a flare-up, number one, infection. Okay, so we really, really need to watch that. But two, hot temperatures. And remember, generalized hot temperatures. Your MS patients also often develop muscle spasticity and some, you know, some tightness of the muscles and that too. You can use localized application of heat that will help relieve the muscle symptoms, but I don't want to do a generalized thing. They would not, you know, it's not good for them to be in a sauna. It's not good for them to be in a hot tub, really out in the hot, humid weather. Okay, those things will all precipitate a flare up. Okay. Parkinson's, you know, we talked about that being progressive, you know, again, that's going to affect their mobility. Now, take it a step further, go back to fundies. You had a basic unit on mobility and immobility. So as your patients with your chronic neuro disorders, as they progress and they have more issues with mobility, so they're not moving as well, they're not up and moving as much, think about what the effect of that is on their skin. Okay, risk for skin breakdown. Think about what the effect is on their GI tract. How does that impact moving their bowels? And go back to that basic stuff. Okay, if you go back to I think it was Unit 4 and fundies that y'all had. Okay, your patient has constipation. What do? Increase the fiber, increase the fluids, get them up and moving. Those are the three things you want to do first, non-pharmacological, before we move on to your bulk forming laxatives. And then if that doesn't work, then you need to look at some actual stimulant laxatives. But those are always the last resort, because at that point, your patient's going to become dependent on it. You know, you always want to go least invasive to more invasive. So we want to start with non-pharmacological things before we move on to your pharmacological things and enemas and that sort of thing. So, you know, that's when you're looking at those chronic neuro conditions, you know, that's what we're looking at. We're looking at how do you maximize function of the different body systems and how do you prevent complications? So they're not moving around as much. They're going to be at higher risk for DVT. So what are we doing to help prevent that? We want to maximize their mobility. So how do we do that? You know, active and passive range of motion exercises several times a day, okay? Because we want to maintain functioning of those joints. Physical therapy, occupational therapy, muscle stretching, just very, very important to kind of maintain that function. Okay, dosage calc. I thought heparin was on the last unit. Is that the type of dosage calc that might be included in this exam? I would say yes, okay, because some of your stroke patients, the ischemic stroke patients, they may be treated with anticoagulants. And that's kind of going to be very much based on the facility protocol and the provider preference. But you do need to be familiar with heparin drips and how to titrate heparin drips. But remember, everything is there in the protocol for you. You do not have to memorize the protocol. Okay, it's there. The biggest thing, and everybody last time did okay with their math. People that missed the dosage calc last time, it was because they did not round the weight. Okay, so for an adult heparin protocol, and it says there in the protocol, the weight gets rounded to the nearest 10 kilograms. So people that didn't round the weight, their math, if you followed it through, was correct. So they know how to do the problem. The issue was they didn't round the weight. Okay, so that's just something, you know, you need to make sure, look at the protocol. It's there for you. It's not something you need to memorize. It's not something you should memorize, because depending on where you end up working, your protocol may look different. Can you go over warning signs of cancer? Sure. So those are obviously going to be, you know, specific to the type of cancer. But here's the big thing that I really want you to keep in mind. When the patient notices a change, okay, it indicates that something's going on. It might not be cancer, it could be something else, but it's a prompt that it needs to be evaluated. So for example, when we talked about skin cancer and we talked about examining the skin and looking at moles and looking at lesions. We talked about the ABCDE. So asymmetry, you know, borders, color, diameter, evolving. Is it changing? Okay. For bowel and bladder cancer, one of the key things that we look at is a change in bowel or bladder habits. Okay, so your patient knows what's typical for them. You know, so if you have somebody who they poop every other day, okay, all right, that's their norm, that's their typical pattern. You know, so if they're doing that, I'm not concerned. If I have somebody that, you know, they generally move their bowels 3 times a day, and now they're not going every other day or every 2 days, that's a change. Again, it might not be a cancer, but it's definitely a change that prompts them to be evaluated. Now, obviously, some changes you can tie back to an occurrence. You know, all of a sudden I'm peeing more. Well, are you on a diuretic? Did we just start a diuretic? That kind of makes sense. But it's really important as nurses to teach your patients when they're experiencing a change in function, that should prompt them to be evaluated. Okay. Same thing with a change in bladder habits. And not even just habits, but sometimes even the appearance of the urine. Microscopic bleeding, sometimes even gross bleeding that you can see with your eyes is indicative of bladder cancer. If you go back to Unit 2, we talked about painless hematuria. So if they're noticing a change either in their habits or in the urine, in the bowel habits, in the stool, that's something they definitely want to check out. Same thing when we talk about like esophageal cancer. If all of a sudden they're starting to have problems swallowing, they're seeing an increase in reflux symptoms. You know, again, it's a change from what they typically experience. So that is definitely something they need to get checked out. So those are the things you really want to focus on. And then of course, you know, obviously the screening tests we talked about, because we do want to encourage patients to, you know, participate in those screenings. Again, screenings are not going to diagnose cancer. They're going to identify patients that are showing signs that something is off. So maybe they hemoculted the stool and it's positive for blood. Or, you know, they did the pap smear and there's some abnormal cervical cells. Again, that's not diagnostic of cancer. They need to do the biopsy, but, you know, it's there to kind of screen patients to determine, okay, this is suspicious. We need to take it to the next level for diagnosis. Do we need to know specific functions of each cerebral hemisphere, or just that the right controls the left and vice versa? So you don't need to get into the nitty-gritty of the specific functions of each hemisphere, but key things to understand about that. If the hemorrhage or the blockage is in the right side of the brain, it's going to affect the left side of the body. That's where you're going to see the hemiparesis, the paralysis. The other thing on the right side of the brain, that tends to be your critical thinking, your judgment, your insight into situations, sometimes math calculations. So you may see some deficits in those areas. Now, if the problem's in the left side of the brain, again, you're going to see the weakness, the paralysis on the right side, but the left side contains the language center. Okay, so when you have a patient who experiences a hemorrhage or a blockage on the left side, they tend to have problems with language. Not even so much speaking or saying sounds, but they have issues with receptive and expressive aphasia. And that can be very, very frustrating for these patients because, one, if they have receptive aphasia, they don't understand what you're saying. You're speaking to them in short, simple commands, but their brain just can't process it. Or if they have expressive aphasia, they can understand what you're saying, but they can't get the words out to be able to respond to you. They can't, string the words together to get that thought out. And that is just very, very frustrating. So, stroke patients as a whole, it's challenging for them, but that left-sided piece, because it controls the communication, those patients really struggle with that because it's very hard for them to get their needs known. So, you know, when you think about establishing communication, very important that, you know, you're using simple phrases, but we can use things such as picture boards, you know, just very basic things that they have. You know, you can print them off the internet. They're a paper you can put in a page protector, just basic things like eat, bathroom, you know, just some basic things that, you know, they can point to so they can get their, you know, needs across. That's very important. Again, that left-sided brain houses that communication center. So you see, you know, issues with that. Are all hemorrhagic stroke patients ventilated to follow bed rest precautions, or does it depend on the patient and the severity? Okay, so with that, with the hemorrhagic stroke, it really depends on the location of the stroke. Most of the time, if you're, you know, if your patient has a true hemorrhagic stroke, we're looking at the rupture of a major vessel, and probably about 80% of the time it's going to be the thalamic artery, either on the right side or the left side, but it's going to be the thalamic artery. With that, because that is a major vessel, they will do the sedation and the intubation. So that's pretty typical of a hemorrhagic stroke over the first couple days. Now, in other cases, when it isn't a rupture like that, when it's a rupture associated with an aneurysm, the aneurysm, sometimes they rupture and they just bleed, like it's a big bleed. Other times you can have a leaking aneurysm, so it's a little bit at a time. If that's the case, if it's a leaking aneurysm and the goal is to take this patient to surgery so they can go in, very similar to how they do a cardiac cath, but now they're going up into the cerebral vessels to coil and deal with the aneurysm. In that case, they'll do aneurysm precautions until they get them to the surgery. But remember, with your hemorrhagic stroke patients or with your aneurysm patients, anything that's going to raise their blood pressure is going to put them at risk for rupture, rebleeding, and increase their intracranial pressure. So it's very important with that we want to keep these patients as low key and sedated as possible. Okay. Would a patient in a myasthenic crisis typically be ventilated to maintain the ABCs? Yeah, typically whether we're talking about myasthenic crisis or we're talking about cholinergic crisis, because remember, they're two different things. Myasthenic crisis, your patient is essentially under-medicated. It's usually either because they haven't taken enough of their medication or they're experiencing an acute exacerbation, a lot of times because of an infection, and the medication needs the level of medication that their body needs, their regular dose just doesn't meet their needs. So in that case, we're always looking at airway, breathing, circulation. So yes, we're going to treat that by increasing their medication. But in the meantime, we need to support their airway, breathing, and circulate. Well, for them, more their airway and breathing. With the cholinergic crisis, on the flip side of that, this patient has had too much medication. So typically they've either taken too much or the medication dose that they were taking is now too much for their condition. Where we typically see this is in a patient right after they've been treated with plasmapheresis or right after they've had the thymectomy, where they've removed the thymus gland. And what happens is the medication that they were taking, the typical dose, is now too much for them. So then they're over medicated. In cases like that, that actually increases the secretions that they have, which causes an issue with airway management. And then the muscles, it's not an issue with not having initial muscle strength, but those muscles essentially go into like twitches and spasms, and it can only do that for so long before the muscle tires out. So in that case, again, yes, we still want to maintain their airway and ventilation, and we're obviously going to treat the cause of the underlying problem. You know, in myasthenic crisis, we're giving more of the medication to get them up where they need to be. In cholinergic crisis, we're giving the reversal agent. We're giving atropine to get that back balanced. But again, in the meantime, while we're waiting for that to work, we still have to support the ABCs. Okay, will questions specific to the case study be on the exam? No, there is no specific question on Susie on the exam. However, the case study is very beneficial in helping you understand the concepts of oncology, but there is no Susie specific stuff on there. What happens when a patient's symptoms of an ischemic stroke have been longer than 4.5 hours? What medications will be given? So again, after that 3 to 4.5 hours, the benefit versus the risk of using TPA, that ratio changes. So it's not as beneficial. It puts them at higher risk for hemorrhage, and the benefit that they would have gotten from reversing the initial onset is not going to be there. So what we'll do with patients that present with an ischemic stroke greater than 3 to 4.5 hours, we're basically looking at keeping that clot from getting any bigger. Okay, so we'll do that sometimes with anticoagulant therapy, a lot of times with aspirin therapy. Okay, just to make the platelets slippery. We don't want that clot to get any bigger. Just like last unit where we talked about DVT and PE, your body will break up that clot on its own. It usually takes about 7, 10, 12 days for that to happen. So the goal is for that clot to not get any bigger and cause more problems. But that's going to be our focus. We're not giving TPA at that point to break up the clot, because even if we reestablish the blood flow, the damage has been done. It's not going to make a whole lot of difference on the deficits that they have. We focus on keeping the stroke from getting bigger, and we focus on getting them to the rehab phase to maximize their function. And then, of course, particularly for ischemic stroke as well, we look at modifying their risk factors, because something put them at risk for that ischemic stroke or TIA to begin with. And obviously we want to prevent any future ones as well. So then we start treating those risk factors. Okay, as the cancer progresses and metastasizes, do they stage grade each tumor, or do they only stage grade based on the original one? Great question. It's based on the original one. Now with the staging, they can do that several different ways. So they can do that based upon diagnostic testing. So for example, as Susie described in the case study, that day in the office, he did the exam, he did the core biopsy, it came back positive, and then the next step was, you know, what she called the discovery phase, where they were essentially scanning her entire body to see, has that tumor progressed, you know, regionally to the nodes, has there been distant metastasis? So a lot of times that's going to be done through, you know, CT scanning, PET scanning, things like that. Now, they can also do that surgically. And you also heard Susie talk about in the case study, they waited, once they did her surgery to remove the tumor, it was at that time they removed and tested her nodes. They can also do biopsies of nodes at that time, and you kind of look on your PET scans to see what shows up. You can see, you can kind of see if there's some node involvement there. But they're going to stage and grade based on that initial diagnosis. So great question. Do we need to know each of the growth factors? I'm assuming you mean on the worksheet. Yeah, they kind of all fit with your pancytopenia. You know, very common, well, essentially it's going to happen to any patient receiving chemotherapy. They're going to have a decrease in those blood counts. That doesn't mean that every chemotherapy patient is going to receive all of those growth factors, but depending on what their labs show, that may be part of the plan of care to help manage the anemia, the neutropenia, or the thrombocytopenia. So as a nurse, you know, you need to know the medications. You need to know, okay, how, you know, when would we use them? How do you know when they're, you know, working? You know, if a patient has a low white count and we're giving this medication, how would you know it's working? Well, one, we don't want them to get an infection. So clinically you could tell that way. But two, you would repeat that blood work. You know, if the purpose of giving this medication is to increase the white count, when we run the CBC with differential, we should see an improvement there. You know, and the other thing to keep in mind is these medications are not the first line thing that we do. So for example, with the thrombocytopenia, we don't start giving the Numega until their platelets get below 50,000. Now, if you look at your normal range, depending on what reference you're looking at, you know, it's 140,000 or 150,000. You know, 50,000 is pretty significantly down from that bottom end of that normal range. So we don't necessarily start with medications right off the bat. But for the platelets, once we get to 50 grand, you know, 50,000 or below, you know, now your patient is at significant risk for bleeding. So at that point, yes, we need to start using that medication. You know, so as a nurse, what are we using them for? How would I know that they're working? And then for the pancytopenia in general, what additional interventions would I be using for somebody with neutropenia, thrombocytopenia, anemia? Okay. Can you explain what infliximab would be used for? So that is a immunosuppressant. It's essentially, you know, your interferons and immunosuppressants are similar, but that's an immunosuppressant. So they use that a lot for multiple sclerosis. And if you think back to the patho of MS, it is an autoimmune disease. So that your body's own immune system is going haywire and it's attacking the myelin sheath on the nerve cells. Okay, so the purpose of using an immunosuppressant is to kind of chill out the immune system a little bit. Like, you know, hey, I need you to do part of the job, but you're just going a little haywire here and you just need to chill out a little bit. So when you think about those drugs, again, look at it from a global perspective. What is an immunosuppressant? Why are we giving it? How does that make sense for MS? And then you think about, okay, I'm doing this to control the MS, but what's the downside to this? Anytime you give an immunosuppressant, that's going to make that person at higher risk for contracting an infection. And with MS, that is a double-edged sword, because if they contract an infection, that's going to cause a flare-up of their MS. And then they're going to require the acute IV corticosteroids to kind of get that flare up under control. So it's really a balancing act when you think about your MS. You know, we do want to suppress the immune system a little bit because we don't want it going haywire, but we don't want to suppress it to the point where they are so immunocompromised that they're picking up infection after infection. Okay. All right, can you explain the difference between PT, INR, PTT, and the numbers we need to know? Okay, so let's start with the differences. So PT, INR, you know, prothrombin time and the international normalized ratio, those are associated with warfarin therapy, okay, Coumadin therapy. When a patient comes in with a clotting disorder, anemia, anything like that, they're going to do a blood panel. They're going to look at they're going to draw all three of these numbers. However, ongoing, I'm not going to draw a PT-INR unless my patient is on warfarin. Okay, we're using that Coumadin therapy. The PTT is very specific to heparin. And where you see the PTT numbers that we monitor is with an intravenous heparin drip. So in general, when you're looking at the PTT, you have to kind of think about the blood in this format, okay? I am not on any type of anticoagulant. So if you drew blood out of my arm today, all of my results are going to be normal, okay? But for somebody with a stroke, for somebody with a DVT, for somebody with a pulmonary embolism, I don't want their blood to be normal. I don't want it to be forming clots. So I need to get them anticoagulated a little bit. Not to the extent that they're going to spontaneously bleed out, but I don't want them normal where they're more prone to have clots because they have narrowing of the vessels or AFib or something like that, okay? So when you're talking about using an anticoagulant, it's not thinning your blood. It is not thinning your blood. So I just want to be very clear on that. But what it does is it makes your blood take longer to form a clot. Okay, it doesn't spontaneously clot, it doesn't clot very easily, but they're not hemorrhaging out either. It's that nice balance in there. So the PT-INR, they will use that to dose and monitor warfarin, Coumadin therapy. Whereas the PTT, we're going to use that to dose, monitor, titrate your IV heparin. Okay, now in relation to the IV heparin, you're always looking at the titration protocol. So you're looking at that protocol. The very bottom part of the protocol says, if the PTT is this amount, this is what you do. Okay. You know, if it's this amount, this is what you do. The INR, the PT-INR for warfarin, in general, at a minimum, the INR needs to be above 2. Okay. Usually when we're treating a DVT patient, you know, we'll start them on Lovenox and oxyparin shots, and we start them on warfarin, and we keep them on the Lovenox until their INR is therapeutic, so above 2. At a minimum, if your patient needs to be anticoagulated, the INR has to be at least 2. What the target INR is going to depend on the individual patient, and it's going to depend on why they're on warfarin. Somebody with a DVT PE, you know, we're looking, ideally, I want them closer to like 2.5. Okay, at 2, I can take them off the enoxaparin because my Coumadin is doing what it needs to. But if I'm talking about somebody with a mechanical heart valve, okay, so not a tissue valve, not a pig valve, anything like that, but an actual mechanical heart valve, then I want their INR between like 3.5 and 4. Okay, so you know, I can't really give you a hard, fast number on the INR because it depends on why your patient is on it. But do understand your PT-INR relates to warfarin or Coumadin therapy and how they monitor and adjust that. Your PTT is related to the intravenous heparin therapy. Okay. All right. Just clarifying, relating to previous question about strokes in the left or right. If a patient has a stroke that leads to right-sided weakness, it means they will have language and analytical barriers because it affects the opposite side, which would be the left. That is correct. So your left-sided brain stroke, so either the hemorrhage or the blockage was in the left side. Because that controls the language center, they will have more issues with communication. They will also have issues with the right-sided hemiparesis or hemiplegia, okay? On the right side of the brain, if the right side has the hemorrhage or if it has the, you know, the blockage, you're going to see the left-sided hemiparesis, the left-sided hemiplegia, and you tend to have some issues with impulse control. They have very poor judgment. For them, they can usually speak. Now, their words may be very slurred because of the weakness of the muscles of the tongue and in the mouth and the swallowing, but they can usually speak. Understanding them is a totally different, you know, ball game there. The language issues that you tend to have will be more left-sided brain disorder, stroke. Okay. All right. I think that is all the questions. Anyone have any last-minute questions? Oh, okay. Here we go. ATI practice test had a question regarding hematocrit and hemoglobin. Both values were lower, but one of the answers was volume excess, cellular hypoxia. Okay. I'm not quite sure which one you're referring to, but I'm just going to kind of go with what you're saying here. Fluid and electrolyte in general, when we talk about hematocrit, remember that is the percentage of red blood cells in relation to the plasma. So if you have somebody that's dehydrated, their hematocrit is going to be high just because there's more red blood cells in proportion to the plasma. If you have somebody who's overhydrated, you're going to have a lower hematocrit, again, because of the lower percentage of red blood cells in relation to the plasma. So there's that piece. Okay, red blood cells that are too low can result in cellular hypoxia. Okay, all right. Yeah, okay, that makes more sense. All right, so when you have a patient who is anemic, okay, they have fewer red blood cells, which is also then going to translate to less hematocrit, less hemoglobin, because they all tie together. Your red blood cells hold the hemoglobin. The hemoglobin is what holds on to the oxygen that gets transported to the rest of the body. So when you have somebody who has low hemoglobin, low hematocrit, low red blood cells, they don't have the oxygen carrying capacity that somebody who has a normal CBC will have. Now, that being said, yes, that can result in cellular hypoxia, but you have to look and see how low are we talking about. You know, when you look at your normal, you know, hemoglobin hematocrit ranges, And it's the rule of threes. If nobody has ever taught you that, it's the rule of threes. So your red blood cell count, if you look at your red blood cell count to your hemoglobin should be approximately 3 times your red blood cell count, okay? And your hemoglobin, when you go from hemoglobin to hematocrit, your hematocrit should be about 3 times your hemoglobin. So that's just like a nice way to kind of keep that straight. But it's going to depend on how low we're talking about. You know, there's people that walk around with anemia all the time. You know, their hemoglobin is in the 10s, maybe even the high 9s. That typically, if it's a chronic anemia, is not going to cause a problem because it's developed over time. Well, let me rephrase that. Not that it's not going to cause a problem, but it's developed over time and your body has had time to adjust and adapt to that. Okay. Versus if it was a very rapid drop. Okay. You know, I was in a car accident, you know, nobody knew what my labs were before, but if we say my hemoglobin was 14 before, I was in an accident, I have hemorrhagic shock, and my hemoglobin is now 8.6, I'm going to be very symptomatic because that was a very rapid drop and my body didn't have time to adapt to that. Now, that being said, even with a chronic anemia, once it gets generally below 8 and certainly below 7, there is definitely going to be cellular hypoxia. So that patient at that point requires a transfusion. Typically, we will transfuse once they get below 8. Okay, because, you know, at that point, they do not have the oxygen carrying capacity to keep up with body demands, body needs, and we need to address that. And at that point, you know, erythropoietin and eating an iron-rich diet and B12 injections are not going to do it. Okay, that's not enough to be able to address that. So, you know, when you talk about cellular hypoxia, you know, it really depends on, you know, what we're talking about, the level. So I'm going to come down here. So, okay, it was like 2.3 and it said it requires a transfusion and supplemental oxygen. So if you use the basic rule of threes, okay, if the red blood cell count was 2.3, in general, the hemoglobin is going to be 3 times that. So if I do that, that would mean that patient's hemoglobin is 6.9. So yes, at that point, it is going to require transfusion to get it up. I'm also going to always put supplemental oxygen on that patient because I want to maximize the amount of oxygen that is being carried by the hemoglobin that's there. So if you would be looking at that, if we go back to the 2.3, so if the red count is 2.3, figure 3 times that would be your hemoglobin. So then you're looking at about 6.9. Okay, and then if you go 3 times the 6.9, that would be your hematocrit. So just to kind of, you know, use the rule of threes with that. Hematocrit is a ratio to serum, not to volume. Well, yeah, I mean, when we're talking about the serum, I'm talking about the portion of the blood that's plasma, okay, the volume of plasma. If you go back into your fluid electrolyte acid base, I think there were probably some slides from last semester that looked at that. You know, if I would draw blood from a patient who is dehydrated and they take that vial, they spin it down in the lab, all the red blood cells are going to fall to the bottom, all the plasma is going to go to the top. And if you're looking at that ratio of red blood cells to plasma in a dehydrated patient, fluid volume deficit, I'm going to have more red blood cells than plasma. On the flip side, if I drew blood from a patient whose fluid volume excess, they're overhydrated, did the same thing, spun it down in the centrifuge and looked at the vial, I'm going to have fewer red blood cells in relation to the amount of plasma because that patient is overhydrated. Okay. Now, when we talk about stroke patients, it's very important. We want to get to a normal blood volume. We don't want them dehydrated. We don't want them overhydrated. Dehydration, you're going to have issues with perfusing the brain cells. Overhydration, you're going to raise blood pressure, you're going to raise intracranial pressure. So for your stroke patients, even your hemorrhagic stroke patients that are sedated and they're on the ventilator, we're trying to achieve a normal volume state. Okay, we don't want to be over, we don't want to be under. Okay, so hopefully that addressed that. What is the criteria for TPA? Okay, so first of all, the first criteria for TPA is it has to be an ischemic stroke. You have to rule out hemorrhagic stroke. because we absolutely under no circumstances would ever give that to a patient with hemorrhagic stroke. So that's your number one criteria there. We have to rule out hemorrhagic stroke with that non-contrast CT scan, okay? The next step is going to be, what was the onset time of the symptoms, okay? Because we have to, if it's not less than 3 hours, and your book talks about how they can go up to 4.5 hours, it really depends, but we really try to stick with that 3 hour window. If it hasn't been within that 3 to 4.5 hours of symptom onset, they're not going to be a candidate for TPA. Okay, they're just not. If they are within that window, that 3 to 4.5 hours, then we kind of go to the next step. You know, was the patient on any type of anticoagulants? Were they on aspirin therapy? Because those things could potentially disqualify them. Do they have a history of recent surgery, typically within the last month? Do they have a history of GI bleed? Do they have a history of ulcers? Things that would already predispose them to bleeding, that if we gave them TPA, you know, could prove very detrimental to them. There, years ago, I actually took care of a patient, and it was a young lady. She was like, I want to say maybe 21, 22, you know, had been on a spring break trip with her pals. They, you know, it was a road trip. They didn't fly. And, you know, they were in the car a long period of time. They weren't really stopping, taking breaks. She was a smoker, and she was also on oral contraceptives, two big risk factors for the development of DVT. Well, she had developed clots actually in both legs. And when they got to their destination, had gotten out of the car, was walking around. Of course, those clots dislodged from the legs and went right up to the lungs. And she had what we call, it was a massive bilateral PE, but we called them saddle PEs. And what that means is her PEs were right at the bifurcation of the pulmonary artery. So the pulmonary artery comes off of the right ventricle, okay, goes up into the lungs, and then it bifurcates to the right lung and the left lung. So she had a saddle PE that was literally at the bifurcation. So it was causing massive obstruction of blood flow to both lungs. So in her case, normally she would have been a primary candidate for TPA. However, at the time all this was happening, she was also menstruating. So she was, you know, having her cycle. And at that point, had they given her TPA, yes, it would have opened up that, but it would have put her at major risk for uterine hemorrhage. So they elected to not give her TPA, even though, you know, she met different criteria. And they actually took her to the OR, and they went in there and actually removed the clots. So obviously getting to the lungs is a lot easier. You could do an endoscopic procedure, but, you know, through, you know, like cardiac cath, but you could also do an open procedure. Depending on where it is in the brain, it may not be an operative, operations may not be an option, okay? All right, can you explain why they give levodopa and carbidopa together? Yes, so levodopa actually helps, you know, the brain produce, essentially have more dopamine in there. The carbidopa helps keep that dopamine there and not be destroyed as quickly. Because if you think about just basic neurotransmitter function, the dopamine can't be there forever. It's there to do a purpose, and then the body has a way to, you know, destroy it. And then more is made and it destroys, and it's just a cycle. Very similar to how clots are made and broken up. You know, your body does it all the time. So the levodopa is going to provide the additional dopamine. The carbidopa is going to help that dopamine stay there longer to do the job. So hopefully that helped. And remember, you know, yeah, that's true. It also has the blood-brain barrier there too, but that's also why the levodopa, carbidopa, you want to space that away from meals with protein, because in order for that to get across the blood-brain barrier, it has like special channels that it goes through, and protein can block those channels. So we still want to make sure they're getting adequate protein, but we need to make sure that you're spacing levodopa, carbidopa at least an hour away from the protein meals. And you want to use, with your Parkinson's patients anyway, to maximize their nutrition, you want to use small, frequent meals. You just need to kind of think about those in relation to, in relation to the timing of the medication. Yes, temp control is important in hemorrhagic patients. Yes, we would not give them aspirin. If we needed to control their temperature, we would use acetaminophen. And acetaminophen is available now. It actually comes in an IV form as well, but we could also use acetaminophen suppositories to do that. You would never, ever, ever give aspirin to a hemorrhagic stroke patient, especially in that initial acute and emergent care. We just, because that's just going to cause them to bleed more. And we definitely don't want to do that. But you are correct that we do want to control the temperature, because if their temperature would spike, that's going to put them at risk for seizure. And obviously that's going to raise intracranial pressure. And that's something we definitely don't want to do. So very good questions today. All right. Any last minute questions? I think I made it all the way down. Let me just scroll back up and make sure I didn't miss anything. If I did miss a question that you had, you can retype it in. I think I hit everything. Pretty sure I hit everything. I'll just give it a minute here, see if anybody has any additional questions. Just keep in mind, you got this. You know this information. It all goes back to basic safe care. Think about, you're the nurse. What do you need to do to take care of this patient? Make sure you're reading your questions carefully. Okay, make sure you're reading your questions carefully in order to, know what the question is asking. Particularly when you talk about like cancer patients, or you talk about treatments, what is going on with the patient? There's some things that are very similar. There's other things that are different between the diagnoses. So make sure you know what the question's asking. Was there a med that you said caused bone destruction? I'm not quite sure what you mean. I will tell you, corticosteroids as a long-term side effect do cause osteoporosis. So that may be what you're referring to. I'm not quite sure. There is now your colony stimulating factors, particularly, your filgastrum, and that those do cause bone pain when we give them. When we're giving those colony stimulating factors, because they work by stimulating the bone marrow to produce more of those blood cells. A side effect of that is bone pain. So that can come into play. Bone marrow destruction, if we're talking about somebody who's going to be having a bone marrow transplant, they receive high doses of chemotherapy and high doses of radiation to completely destroy their own individual bone marrow before they receive the donor marrow. So I'm not sure if that's, what you were referring to. The only other thing I can think of is your corticosteroids, the IV corticosteroids that we use to treat acute flare-ups of your MS. Those will, over long term, if you're using them long term, is going to affect the absorption of calcium and is going to predispose those patients to osteoporosis. So that's the best I got on that one. Okay. Yes, the Neulasta shot does cause severe bone pain. That is a very common side effect of that because we're trying to raise those white blood cells. It's going to stimulate the bone marrow to do that. So it does cause that severe bone pain. So, and Susie talked about that in her video as well, how that was one of the major symptoms that she had, was to make sure, to manage that pain. So again, we talked about around the clock dosing of pain, and then using, with your longer acting ones, and then using your short acting medications to deal with the acute breakthrough pain. Okay, we got another question. So after a carotid endarterectomy, neurological observation is used. Yes. So remember when we talk about risk factors for stroke, and in this case, we're particularly talking about ischemic stroke. So in the carotid arteries, particularly where it bifurcates the internal and the external carotid artery, that tends to be where plaque buildup will accumulate. And patients that experience TIAs, so these would be the mini strokes where they have temporary short-term blockages, usually things get caught in that carotid artery. So as a preventive measure, if they diagnose somebody with carotid stenosis, plaque buildup in there, they can do a carotid endarterectomy, which is where they will actually go in and surgically remove some of that plaque, with the whole goal being to open up the circulation. I'm getting better blood flow to the brain, and I'm removing that plaque, so hopefully platelets and other things aren't getting stuck there, creating a blockage. The risk of those is that you can have a portion of the plaque break off and then move along with the circulation and then get lodged someplace else in the brain. So that's a risk. It's a known risk of this procedure, but that's why it's very important to monitor these patients very closely afterwards, because if they start having neurological deficits, and remember, a neurological deficit is not just a change in level of consciousness. It can be a change in orientation. It can be speech difficulty. It can be weakness on one side of the body. Any type of neurological deficit indicates that there could be a potential complication from the carotid endarterectomy procedure. At that point, that is definitely something that the provider needs to know about, because now you're talking, here we're trying to prevent it, but we experienced a complication, and now you're actually seeing, the potential stroke happening right in front of you. In that case, it's not because of a blockage, like a clot blockage. It's usually because a piece of that plaque has broken off and that has become lodged. Now, obviously, if I give TPA, TPA doesn't eat up plaque. It eats up blood clots. So, that patient is not going to be a TPA candidate. But yeah, so that's one of the things that you're monitoring very closely for after carotid endarterectomy. And that is something that if you notice, you assess, and there's a neurological change. I know I told you 99% of the time, notify the physician is not the correct answer. In that case, that is the correct answer, because there's nothing more that you can do. I mean, I'm going to put oxygen on them. I'm going to try to maximize what I can do, but I need to call the provider because that patient needs to be evaluated. Depending on where it's lodged, they may be able to go back in, similar to like a cardiac cath, but going up into the cerebral arteries to open up the blockage. It really depends on the situation, but that would definitely be a notify the provider. That's a critical piece. So, oh, and Heather got to see one of those. Yeah, they are pretty cool how they go in there and they kind of suck the fat out and everything, the plaque. It's really neat. So, all right, any last minute questions? Going once, going twice. Okay, well, happy May, everybody. Let's get this done. Once your grades are posted, then all of your numbers will be in there and you can do your grade calculation and you can see exactly what you need on the final, both to pass, to get your B, those of you striving for an A, see what you need to get an A. And do that. I think when you do your grade calculations, a lot of you will be pleasantly surprised. So, all right, have a great rest of the day. Rock the exam. And I will get grades up tonight once that's done. Of course, it might be a little bit late. I will do the topics to review list. That might take me till Monday to get that done, but I will get grades up tonight. So, all right, rock it. See you later.